Welcome to Mental Health Awareness. I'm Dr. Ann Coretti, Director of Student Services for the Nauset Public Schools. And our guests today are from Gosnold. And today we're going to talk about opiates. So welcome. We have Laurie McCarthy, Clinical Outreach Director. We have Patty Metro-Costas, Director of Prevention from Gosnold. And Kevin Rosario, Community Outreach Coordinator. So the first question I'm going to ask is, what are opiates and why are we hearing so much about opiates?
So opiates is any medication that's derived from opioids, I guess. So typically you'll find like the Percocets, the Oxycontins, morphine, fentanyl, heroin, all kind of fall under that umbrella. It really attacks a certain part of the brain. The brain actually has opiate receptors, and what happens is a person that takes that gets that like endorphin-like feeling, I guess, that endorphin-like high, but it's very addictive. And after a very short period of time, the body craves it, and it goes through that withdrawal period. That's how they're actually getting sick, is when they flood the brain, the opiate receptors, with the opioids, and then when they try to stop, the body goes through a withdrawal phase of trying to like crave more of that, and it takes a period of time for the body to stop producing that at a regular rate again. And that period is like the withdrawal period. If that explains it a little bit.
Yeah, it floods the dopamine system.
Yeah. So.
And the withdrawal period, could you talk about that? Like how long is a withdrawal period? It must vary from person to person. And
I think it depends on where they are, where someone is in the dependence.
Okay.
And what opiate you're using, whether it's heroin, whether it's oxycodone, OxyContin. It's really going to depend on the history of use and what that withdrawal is going to look like.
Where are the drugs coming from?
Well, I think that's a scary statistic that 70% of people who begin using an opiate, a prescription opiate, get it from a friend or relative, oftentimes from medicine cabinets. So it's not an illegal buy to begin with at 70% of the time. It's right from a friend or relative. So very easy to access, or from their own physician. So it could be their own prescription that they become dependent upon, or it could be that of a friend, a relative, a neighbor, grandparents.
So a doctor might prescribe an opiate after surgery, for example, maybe OxyContin. I don't know if a doctor would prescribe heroin for anything.
No, heroin is the illegal form, if you will, of an opiate, it's a purer form of opiate that would not ever be prescribed by a doctor. They would prescribe, as you're saying, an OxyContin, a Percocet, Vicodin, from those families. Sometimes fentanyl, which is in the form of a pain patch, is prescribed after surgery. But these drugs, particularly OxyContin and fentanyl, I mean, they were originally manufactured for the purposes of end of life and serious cancer pain, post-surgical for a very short period of time while you're managed inpatient. They were not intended for use of after minor dental surgery or some of the other things that I think over time they became used for. It's been an unintended consequence of the lack of education on the part of many of us as public, as parents, as physicians, that didn't realize the initial, addictive properties of a lot of these medications. So I think we're seeing a lot of the unintended consequences, and the switch to heroin comes when the pills are no longer available. They're much more expensive, 10 times the price of a bag of heroin. So that, as Kevin pointed out, the dependence becomes so high and so strong in terms of how it's affected your brain chemistry that you'll switch to whatever substance you need to use. And in most cases, after the pills, it becomes heroin.
How much is a bag of heroin? How is that sold? By the pound, ounces?
It's hard to say. Some people sell them in like small plastic baggies. You could get anywhere from a $20 bag to buy a $200 bag, depending on how much you're doing. If you're trying to A lot of the guys get into buying a bigger bulk and then trying to sell it to offset the expense of their own use. But that's the real problem is you can get a small bag for $10 or $20 and it's easily accessible, you know, it's everywhere now. I used to say it was in the inner city, but it's
No,
it's
it's
everywhere. It's
And-
in suburbs, it's in Cape Cod, it's
Yeah, compared
In
to
the
a
country.
pill
Anything's-
that's $1 a milligram. So if you have a 80 milligram OxyContin, it's $80, or a Percocet, a Perc 30, they call them, that's $30. So $10 compared to $30.
yeah, and the potency is dramatically different. So a Perk 30 is between $25 and $30. You could spend, you know, say $20 on heroin, and it's probably 2 or 3 times the strength, and it's easier to get, you know. So most people make the switch because exactly that. They can't get it anymore, or it's just a finance thing. I'm spending $200 a day on Percocets. Somebody, a friend usually, right? Somebody around you that's also using, who has made the switch, says, why don't you just try a little line? You know, and there's a stigma. Most people fight it. Most people have like, I don't want to do that. I don't want to cross the line. They don't want to do heroin because it just sounds bad. You know, Percocets, part of the problem is it's so common, it's almost socially acceptable among the teens and among the population. But the heroin thing is like, no, I'll never do heroin. I just do Percs. But you get to a point where the physical withdrawal from the Percocets, from any opiate, is so severe. The flu-like symptoms are so severe. It's not about even getting high anymore. It's not about effect. It's about not being sick. It's about combating the withdrawal. So when you're in a corner and you can't get any Percs and you're low on money, if heroin's there, you're going to take it to not be sick. You know, and that's where the behavior comes in. That's where the stealing comes in, the lying, all that stuff. This person's brain has been hijacked. Their body on a daily basis is going through a period of ups and downs, ups and downs. And before they even start to get down, they are so crazed about how they're going to get the next one of whatever it is because they don't want to feel that sickness. And that's when they really get desperate. That's when they do things that are way outside of family values, things they've been taught, the education level, it doesn't matter. It's like a survival instinct. I'm going to be sick later today, and they might try to get a little job. They might try to sell something they own, but when push comes to shove, they go down the line. They're going to steal whatever they can steal. They're going to get whatever they can get to not be sick.
And how long does that wellness for them, let's say not be sick, last? How long?
Not that long, right?
No, it's
An
not.
hour, 2 hours?
It's a very short life.
6 hours?
Most people use between 2 and 4 times a day to maintain that. So that, again, depends on where they're at, their tolerance, their progression in the illness, and how much they're using. Some people might get money and use a lot at once and be like highly intoxicated for a lot of the day. But as soon as they start to become more coherent, and a lot of it's mental too, just the fear of always knowing you're going to be sick puts them into that manic cycle of always trying every day, all day, to get the next one, to just be prepared not to be sick. And that, when they're stuck in that for a little while, that's why it really takes long-term stabilization to break that, because it's so impulsive, it's so strong. It's just
It just consumes your life. That's a lot of energy
it's
trying to
consuming.
think, how am I not going to feel sick in 6 hours? What am I going to do? How am I going to support that?
And that's what's so alarming for families is that it really literally hijacks to the brain to the point where you don't recognize your own child or your own spouse or your own sister or brother because they are not acting how they would normally act. It really is a consequence of the drug that they're on and what's happening to them. And when we explain that to families, that off of this drug and out of this cycle, you will see that this person will be back to the person that you knew. And it's we see it every single day. People that we treat in our programs for an opiate addiction are literally wonderful young adults, wonderful people, filled with shame and remorse at how did they get there, how did it happen, countless stories on a back injury, a football injury, oral surgery, you know, whatever it is, or just my friends did it and they offered me something and I tried it and I liked it. And that's almost like the worst case scenario. If you try it and you like it, that's terrifying. So it's everybody. It's all our communities and
How can
very
you tell
powerful.
if someone's using? Can you tell?
There's sometimes, I guess, the visual signs, you'll see usually weight loss. They'll start to care less about their appearance. You'll see of someone who's well put together, all of a sudden, less frequently they're getting haircuts. If it's a man, they're maybe not shaving. If it's a woman, she's not doing her hair or taking the effort into putting the makeup on. Sunken eyes, dark eye circles,
Irritability.
erratic behavior.
Very
You
erratic
know,
behavior.
they
Yes.
physically start getting sketchy because their mind is racing. And you can see, like, you can look at them and say, are you okay? Because it's not their baseline. Something's off. You know, they're in, like, go mode sometimes because they're seeking. Or they're in
Something's
fear.
wrong.
Yeah, you can,
Something is wrong.
yeah.
Yeah.
It's that trusting your instinct, and then I think later some of the
Yeah.
behaviors that Kevin said folks have to resort to, then some of those behaviors are things missing from your home, is there money missing, is there jewelry missing, is somebody not coming home, some of the later signs, but initially it can be confusing, and I think particularly with young people because, well, kids are, you know, up and down and moody and such anyway, so with teenagers it can be a little more difficult, but I think some of it has to do with, you know, trusting your instincts and seeing who they're associating with and educating yourself as to the signs and some of the risky behavior and some of the things that may put them more at risk. You know, a genetic predisposition to addiction. You know, maybe you want to say no to that prescription that the oral surgeon is offering after wisdom teeth. You don't need that. We can take, you know, Advil or Tylenol instead. I don't need that Percocet prescription because maybe there's addiction in my family. So those kinds of ways, too, that we're trying to educate parents in the community that we can start to take charge of our medical management, if you will, and have those conversations with our doctors and with our dentists and with our family members and community members. I mean, every chance that I'm sure that all of us get that work in the business, you know, we're always spreading the word, as we say, and, you know, ask the questions and look at your family history and do you really want to put yourself or your child or a loved one at risk if you don't need to. Certainly the medications are needed for many people, and they have medicinal properties that have enhanced and enriched many people's lives that are in, you know, very, very difficult pain. So, you know, it's not that we're certainly making decisions for physicians, but asking people to educate themselves on the risks as well.
Yeah,
Are
there
those
should be,
risks worth it?
you know, pamphlets that go along with every prescription on the dangers of dependence and the risks that are involved in taking a medication. I think that's really important.
So that's something that perhaps a loved one should ask. A husband should ask his wife if the wife went for oral surgery and received some medication, said, you know, let me see what that pamphlet says.
Right.
And actually, we
That's
have,
right.
we're putting informational cards, Cape Cod Healthcare and the Community Health Center in Mashpee, and we just left some on the clinic at the Joint Base in Otis, what we used to call Otis, providing information on how to dispose of your medications and to lock them up when you're not using them because they are dangerous for children to get a hold of or anybody that could be in your home that has access to your medication for those that are prescribed opiates. But I think, you know, it's right that we need to educate people on the risks of them as well, those that are taking them, even legitimately from a physician.
Right.
And not to make those decisions, but to have all that
Have the
information. And it may not always be. I mean, I know with my son who recently had his wisdom teeth out, we said no thank you to the Percocet prescription. You know, and for 2 impacted wisdom teeth and 2 others out, he never needed it either. I mean, he took Advil and he was fine. So sometimes just knowing that and being armed with that and not taking that chance if you don't need to.
You're not
So-
allowing a 17-year-old to manage their, you know, they
Manage
they
narcotics.
Go, right, manage narcotics. So parents are taking those, and you know, if they have to have it, they're giving it out as needed and then disposing of it and not keeping it in the medicine cabinet. Because it's, you know, you want to limit opportunity, right?
Absolutely.
With all this stuff, so.
So sometimes when that prescription would wear off, could someone go to another doctor and ask for a prescription refill
Well,
without the
that-
other doctor
Part
not
of the
knowing?
problem.
That was happening all the time, and that's part of Governor Baker's bill is to, with the prescription monitoring system, is that physicians that are writing opiate prescriptions can now look into a database and see if this person has been written a prescription, you know, recently. Or, so, and it's really requiring all physicians that are prescribing opiates to go through the prescription monitoring program. It's going to eliminate all of that because there was a lot of, you know, going to different doctors for different
shopping.
needs.
Doctor shopping.
They
yeah.
call it doctor shopping, and so that's really going to be helpful.
And the pharmacists as well, a second check with pharmacists are part of the prescription monitoring program. So they can look into if somebody's trying to go to Rite Aid and then they go over to CVS with another prescription, all that's going to in a centralized database now. So because you used to just be able to go to different pharmacies or different pharmacy chains and not have it tracked, but much of that is changing. So that's getting to the supply, and it's getting to you know, to some of the limitations on prescription numbers, and even
Which
for
will help.
pharmacists to be able to question.
I just want to go back to one thing. My mind sometimes takes a minute to resonate. When you said, what are some of the signs, and I was thinking, you know, acute. They're already in pretty severe stages. But when you started speaking, some of the other signs are you see a person start to withdraw from their normal pattern of behavior. So if you got to say it's your husband, your wife, it's your son, he's always around. He's at family functions. Now they're not around as much. It's tricky because you might think, oh, he's outgrowing us, he's old, he's this, he's that. But the patient, the person who's addicted, may be trying to hide from you to hide the use. So if you see a weird change in behavior, and then because the obvious sign is someone who's heavily medicated on an opiate or is using an opiate tends to get lethargic and their voice can change. And if they're talking to them, they might be attentive, but if you stop your attention on them, they tend to nod out, they call it. You see like that the body is going, the eyes are rolling back. What's just as tricky, which I don't think a lot of people talk about, is there's a lot of individuals that are like hyperactive. A hyperactive individual who takes an opiate will run around, cut the grass, paint the house. It has an opposite effect. So like, again, if you see a typical, normal, average person who just does this, all of a sudden is like hyper on God, doing everything, Mr. Fix-It. Like, hold on. We appreciate it, and we're glad this is happening, but this is abnormal. Eventually they'll crash, and you'll see that same lethargic kind of nodding out thing. But opiates actually affect people differently, just as some of the other drugs affect people differently. Has to do with their own chemical makeup and stuff. So I've heard guys come in, opiate dependent, and saying, man, when I was using, I was working, I was doing school, they were gung-ho. When the other person uses, they just crash, and they don't have the ability to do anything.
So the behavior you're describing is like manic behavior.
It's usually kind of, in the early, it's kind of harder to catch. Manic's a big word, but it's extreme. It's usually like they're either like really lethargic and like falling down, or they could be like abnormally want to get stuff done. You know,
Happy.
Yeah, way too happy. That, you know, and then again, that period in between. What is their baseline in between? They're angry, they're irritable, they're not okay. They're walking around
sleeping.
all banged up all the time, and then all of a sudden, life is good. Hey, let's go. And like, hold on. You know, we're glad that you're happy right now, but what is it?
What is really
Is it
happening?
induced by something?
Right.
You know,
Right.
So there's a lot of things
Yeah.
that you can see, and this is earlier on, way before it gets way out of control. A person on opiates will tend to have pinned pupils, whereas a person on like amphetamines or cocaine type thing, they have dilated pupils. The pupils get bigger, the black in the middle. A person that is using or abusing opiates has very small, the black in the eye is very small. So if they're in light like this and they have very small pupils, I mean, you know, that could be a sign. You know, I'm not, you know, but if you're suspecting that, those are some of the things you can look for. In the downtime, like Lori said, are they just sleeping all day, every day, going into like that depressive state where like, because it gets to a point where you almost don't want to deal anymore. It's a lot of energy to get up, to lie, to manipulate, to hide it from people, to
Sure.
keep the facade that you're doing okay, to get what you need to function it's when the people come into our facility a lot of times, initially they might fight, but once they get in there, they're like, that feeling of surrender, that feeling of peace, because they've been spending so much energy to keep this up, that they're like, it's over, it's
And
done.
they don't want to do it.
It's taxing.
It's not something that's a choice, and I think that's part of the misconception. You know, it's not a character flaw. It's not a moral defect, because I think people see the consequences and they hate the behavior and they hate what it's led to, whether it's, you know, crime or stealing, hurting people, not keeping your promises, not showing up for your children's events. I mean, this isn't anything that anybody would ever choose. And so I think that that's part of, you know, a great part of our mission as well, is to educate people so that they, again, to destigmatize, to take the shame away from the individuals and their families and the suffering, because that only adds to the suffering, adds to the physical suffering. As Kevin's saying, and part of it is, oh my gosh, I'm disappointing my family, I can't look at my mother, I can't go out in public, I lost my job, I don't have any money. So all of those things just keep compounding and compounding the stigma. And so much of our mission has to do with the education piece, and whether it's in our prevention division or overall at Gosnold. I mean, that's, you know, it's educating everyone, the public, physicians, teachers, students, parents, families, that it's not a character defect. I mean, they're people. When I'm asked by people, like, who are these people? Who are these patients? And I say, they're us.
Everyone.
They're us. They're our children. They're our dads and moms and brothers and sisters. And it's, you know, or often we see the young people now. You know, who are these kids? They're our kids. They're in our schools. They're on our sports teams. They're in our community. It's your, you know, it's your daughter's boyfriend. It's your son's girlfriend. It's everybody. And it's everywhere. And I think the more awareness there is, and the more education, and the younger
And
we
help.
start,
And
and
help.
help, and saying help is there, help and help is here.
We expanded our family support groups this year, so we had always traditionally had a group that met every week in Centerville, which we still have, but also now Falmouth and Harwich. We extended it off Cape to Scituate. So every 4 nights a week, there's a support group and education going on. They don't have to be families of people in our programs. They can be, it's open to the community. Anybody that has any concerns or questions can, you know, come to these groups, and it's led by a professional clinician and certified interventionist. So, you know, we are doing our best to getting the word out, the education, the information that is necessary.
I'm hearing a lot about opiate usage and alcohol usage together.
Yeah.
It seems like these two chemicals contradict each other.
I don't say they contradict. I think they actually enhance and make the effects worse. You know, alcohol is a depressant, an opiate.
That's what I mean.
They- It actually it increases the effect. It doesn't contradict. They actually, so it's more dangerous.
So dangerous.
The one thing that's funny is that it's not funny, but opiate withdrawal, the people are crazed and they do crazy things, right? They feel like they're going to die from these flu-like symptoms, but they won't die. Alcohol and benzodiazepines, those, when a person is dependent on that withdrawal, they can actually die.
Right.
They can go into an alcoholic seizure. So now you start bringing in a crazed mental obsession, a physical withdrawal with the opiates, and now you start becoming a daily drinker. Now you got double issues. You know, now you put yourself in a more dangerous position, and we see it all the time. I feel like a high percentage of people are polysubstance use disorder. They come in and they're doing one or the other, or they're doing one during the day to work, and then one to go to sleep, and then one to wake up, and they just don't have any life skills. They can't function without one thing or the other.
We have to get them back to like a baseline.
Yeah.
What's the baseline?
The
And then go
self-medicating.
from
Yeah, I
there.
need to be awake, so I'm going to try this. I need to go to sleep, so I'm going to do that. So it's sort of all becomes a life of self-medicating. And, you know, even some of those early root causes could go back to depression, anxiety, low self-esteem. I mean, that's what we see through our clinicians in the schools. Are many of kids as early as elementary level showing signs of depression and anxiety, and those can lead to substance use later on as a way of coping.
Well, it's also, too, a cultural thing as well that, you know, being uncomfortable is not, you know, not really okay anymore. So there's something for everything. You know, you
Right.
don't feel good, you can take that. You don't feel it, you know, the minute you're uncomfortable. So it's really helping people to be able to tolerate and know when it's, you know, it requires some type of medical intervention, antidepressant, or, you know, a psychiatric diagnosis, or is it that it's really hard to tolerate just being uncomfortable? And so when someone is getting into recovery, it's knowing when, at what point are we, you know, introducing them to psychologists and psychiatrists to make a more
Get a proper
advanced,
assessment,
a proper assessment
Diagnosis.
of what the diagnosis is.
Well, I agree with you so much about the piece about feeling uncomfortable, you know, and we're working really hard in schools to teach kids self-coping skills,
Yes.
to self-regulation.
Right.
It's almost like you can't have any bit of frustration.
Right.
It's a big problem when it's really an opportunity for learning. You know, how can I help my child self-soothe?
Right.
You know,
How
what
can you tolerate these
Wellness,
feelings and emotions?
mindfulness,
Yes.
different
Right.
Or
things
even
like-
anxiety on a test. I say,
Right.
well, everybody's anxious with tests, and what you do is, what can you do to alleviate it? Prepare, study.
Right.
Some of the you know, more old-fashioned methods. But as Laurie said, I think there's a point where then it becomes, when is it something that needs to be, you know, assessed and consequently treated? But some of those feelings, starting to teach our kids, again, part of our education with some mindfulness and some thoughtfulness, and sometimes you're going to be uncomfortable. Or yes,
Being
you're going to be
comfortable with
nervous.
being uncomfortable.
Yes.
Right, that's exactly
Whatever
right.
happened to just having a little back pain? My back hurts. In a couple days, I'll be okay. Just rest up.
That's
you know,
right.
we're a fixer society.
That's
You're
right.
tired,
Right.
we got something. You got anxiety, we got something. You have pain,
Right.
we got you.
Yeah.
How about some things will just naturally pass?
Right.
And the body is an amazing mechanism that will kind of balance itself out for
Right.
the most part. We have everything we need inside of us to have pleasure, to deal with pain, to help sleep. You know, the chemicals are there. And when we start interacting and interjecting outside things, it actually is counterproductive because it throws the natural chemistry of the body off. And that's what we really focus, how to get that chemistry back into place. And it's long term. It's long. Gosnell, we don't believe in detoxification. Like, you need to wrap these people up in services, give them a strong chance for success, try to keep them inpatient for a while, get them the therapist, the psychiatrist, the outpatient. Like, they're going to need a lot of wraparound support services in order to get it. Just like any other long-term illness, there's no quick fix
Right.
for it.
And they can, with support services, they can still return to the same community. I know that's hard for people,
Yep.
but they can do it.
Absolutely.
Oh, yeah. That's the goal.
They can do it. They don't have to move to, you know,
Happens all the time.
West Coast or something.
Because many people are very embedded in their communities. They are in school, or they have jobs and homes and lives.
That's where their
and
families
yeah,
are.
where their
It's actually a
families are.
delusion. That they call that what do they call it? They call it like an environmental fix type of thing. So they think, if I just go there and get out of this town, I'll be okay.
Geographical cure.
Geographical cure. Thank
There you
you. I was
go.
struggling. The problem is, you bring that same person with you wherever you go. So here I am now. I'm in sunny Los Angeles, and I got anxiety. I got no coping skills. I'm full of fear. I'm fear of other people's opinion. You know, so what happens? I can make it for so long, and then I'll find what I need. So we try to love them up and wrap them up and educate them so that they have the tools they need to go anywhere.
Anywhere.
You can't
Wrap-
hide from this stuff.
Wrap them up and love them up. I
That's
love
right.
that. That's great. Well, Kevin, Patty, Lori, I want to thank you. And if people want to get in touch with you, how can they do that?
Probably the best way is through the 800 number, 800-444-1554.
Thank
All
you.
right, thank
you
you.
for having us.
Thank you.